the videos that I do want you to watch all of them. And it's best to watch them today after we talked about everything. One thing that we talk about is otitis media, but the thing is with this, you'll very rarely see an infant in the hospital with an ear infection. Okay, that's something that you'll probably see in ambulatory care, or if you work in the pediatric area where you work in a physician's office or in a clinic, you will see a lot of otitis media, or in the ER. They do come into the ER with otitis media because a fever can really upset new parents with small children. And otitis media, if any of you have ever experienced that with an infant or a child, it's brutal. It's brutal. They are in severe pain, like 10 out of 10 pain, pulling at their ears, no appetite, very irritable. I mean, they have huge lymph nodes here. Sucking aggravates it. They can't drink a bottle. They can't breastfeed. Temperatures can go as high as 104. And then it says here, after one ruptures, if it does rupture and it starts bleeding and pus coming out of it, the pain is decreased, but they're still in trouble. And in talking about these kids, we treat the symptoms, of course. And in treating the symptoms now, it used to be right away, the first treatment is antibiotics. Now, oftentimes, pediatricians are not doing antibiotics. They're saying that this is viral, treat the symptoms, you give the Tylenol or the Motrin, and you treat with the eardrops for pain, that Arolgan, warm it up put the tube in a little thing of warm water, get it nice and warm, put it in the ears, and that's treating the symptoms. And within 48 to 72 hours, the symptoms start to be gone and it's worked its way out. If that doesn't happen, then they generally will start on like an amoxicillin, but because of the overuse of antibiotics, pediatricians aren't generally using a lot. The other thing that is done is they put the possible surgery for the myringotomy tubes, or the tubes that little kids get when they have chronic ear infections. And sometimes those are just lifesavers for infants, for families, because they aren't, the tubes are too small to process the fluids. They get infections. They are sick all the time. And with this little bit of respite with the tubes, they can get through that period of time. Their tubes mature on their own. The tubes that are put in, they get, expelled, or, they fall out. And kids seem to do very well with that. So it just depends. An outpatient, they're in and out in the same day. The surgery takes like 15 minutes. But wait a second. I'm not sure why that one's first. But we talk about in respiratory systems, the different variances. So the airway is smaller and more flexible. Larynx is more flexible and susceptible to spasms. Lower airway are smaller and underdeveloped cartilage. So I'll show you a picture of that. Their tongue is larger, so it's more difficult for them to manage secretions and their respiratory efforts. Infants less than 6 months are obligate nose breathers. Chest muscles are not well developed. So if you see a child breathing and using those muscles too much, you know that they're straining. Hold on one second. Diaphragm. The diaphragm is the neonate's major respiratory muscle. When they're straining too hard, you'll see that it's a lot of diaphragmatic breathing to where they're struggling with breath. Irregular breathing patterns, periods of apnea, 10 to 15 seconds are common. But for a brand new parent, how scary is that? You're holding your baby and all of a sudden, and they're not breathing for a minute. Or for a new nurse, listening and you're not hearing anything, that kind of thing. So it's, infants breathing and children breathing can be kind of scary. Abdominal muscles are used for inhalation until the age of 5 to 6 years of age. They do breathe faster. Increased BMR raises the oxygen need. In a child versus the adult, you see the long and narrowing where the epiglottis is, and for the adult, it's a lot larger, it's more matured. You have your vocal cords, And in this area, when we do talk about epiglottitis or the inflammation, that it says the epiglottitis is flappier and U-shaped in a child and shorter in the adult. So looking at just the physicalities of your breathing, you're going to look in, you're going to see where the opening is. Here you've got your tonsils. When those are inflamed, there's also an interruption of breathing. A tonsils and adenoids in, you know, I don't want to say trending, but sometime back, you know, when my kids were little, it was take everything out. And then it went through a period where ENT said, no, don't take anything out. It helps fight your immune system. You need those, leave them and treat symptoms. And then again, it's take one or the other out. So it's very dependent on who your ENT is and ear, nose, and throat doctor, your ENT, and what is trending in the evidence-based practice. What is the best practice? Don't just go in and remove everything. And that just shows you just, you know, tonsillitis. It could be viral. It could be bacterial. We do know that it is something that people will go into the hospital. If you have a tonsillectomy, it could be necessary, but oftentimes it is just treating an infection and treating the symptoms. So sore throat, mouth breathing, sleep apnea, difficulty swallowing, and the fever, throat for culture and sensitivity, and a rapid strep to see if it is a strep infection, and that gets treated with antibiotics. Ease respiratory efforts or implementations, provide comfort. The warm saline gargles where you gargle with it, but for little kids, it's hard for them to gargle. It can be hard for an adult to gargle. You'll gag and spit it out, or, you know, like you can't manage that secretion. So gargling for a little child or a little kid can be very difficult. You have pain medications, throat lozenges. Again, for little children, throat lozenges are hard to manage because why? They'll just swallow them and choke. So those are more for an adult, but they do have like a squishy little lozenge for kids that kind of melts in your mouth type of thing that dissolves quickly. That's different. We want to reduce the fever, promote hydration, give the antibiotics if they're ordered, and then provide rest and patient teaching, meaning that patient teaching probably might not be to the child, but would be to the family, to the caregiver, saying that keeping them hydrated is very important. And because this hurts, it may feel good to have popsicles. They have the Pedialyte popsicles, or making sure that you can hydrate this child. See if they have a tonsillectomy. So if in fact they do have to have a tonsillectomy, our responsibility is to do the preoperative nursing care. So they go in, they get their labs drawn. Age appropriate preparation and teaching would mean we're teaching the whole family. If it's, you know, 5 to 9 year old, but the babies, you know, maybe a little bit younger, you're teaching the parents what to expect, how to take care of this child or infant with the tonsillectomy, and you do the consents. They go in for a surgery. The surgery doesn't even take more than 15 minutes. So altogether, maybe an hour and 10, putting them under, doing the surgery, getting them into recovery. And if they're back in post-op, it could be one day overnight so that they can get IV fluids, but it just depends. It just depends on the actual illness of the child and how long they've been sick with this. So frequent site assessments, you're visualizing, you're opening that mouth to see if you actually are visualizing bleeding. Monitor for signs and symptoms of complications, which could be a fever, which could be sucking and swallowing constantly. That could mean that they are bleeding. You want to make sure that you're managing their pain. Push fluids, no citrus because of the acid, and no red in case they throw up. You mistake the vomit for blood or vice versa. You don't want, you know, if you're on Peds, you'll notice there are no red popsicles. Red popsicles are just not a thing on pediatrics. And oftentimes the juice pops they'll have, or the Pedialyte, will have the very faintest color, if any, so that doesn't get mistaken. And then a lot of patient teaching, which would mean keeping the child hydrated, keeping the pain under control, and keeping that pain, hydration, and making sure that there is no temperature. one more thing I wanted to mention about this. If in fact you are on Peds and you get a tonsillectomy, it's going to be for a short term, but it's still one that you can write up about because you're going to care for them. You might not care for them for more than 2 or 3 hours, and then they're discharged home with their parents. So that isn't a problem. If this is who you took care of, that's not a problem for your turn in paperwork, because you might have to get another patient as well, and that's fine too. Again, when you're doing those write-ups, you don't have to do one on every single one unless you have a discharge at 10 and then you have the whole rest of the day. Write up a brief one on what you did in the morning and what you did in the afternoon. Acute epiglottitis is a life-threatening emergency. It can be. So this is one we talk about. Bacterial form of croup. So let's say you have a bacterial infection and these kids are coughing. The coughing and the croup cough generally happens at night when they're going to sleep, and all of a sudden the respiratory effort is going to be trying to be decreased. They start coughing. And once you've heard that kind of cough, you don't mistake it. It's like a bark, a very distinct bark, and like a seal barking. Scary, very scary for parents. I know that generally it's a virus, but bacterial form is also something that the patients get antibiotics for, antipyretics. They keep the temperature down, they keep the antibiotics down, and hopefully we'll show you the epiglottitis to where it's closed. They're able to take something in. If it's not closed shut, they have to get to the hospital right away. HBIG vaccines or reduce the cases, life-threatening emergency. Wellness to complete obstruction in 2 to 6 hours, most common ages 2 to 5. So these are little guys, and parents will sit in a bathroom with a shower going, or actually sit in a bathtub in a warm or tepid-ish bath to keep temperatures down. And that steam helps open up the airways. You don't put a depressor down because you could occlude that throat all the way. If the patient's in the hospital, we have functional emergency equipment at the bedside, meaning there's a trach. There's a trach tray available. You have the mask for oxygen available. And that does sound kind of extreme and scary, but it's better to be safe than sorry. They get a very sore throat, pain, tripod positioning where they're sitting like this in a triangle, and there's a picture of it so that they can breathe because they're having a very difficult time breathing. So positioning is key. Retracting, you can see their lungs are retracting. There's a stridor on inspiration, and you can hear it. It's a very distinct sound. The mild hypoxemia, you'll see kind of a bluish edge, and maybe blanching, you'll see, a little bluish tinge to the fingertips. Drooling, dysphagia, dysphonia, distress, inspiratory effort, all of those are the 4 Ds for an epiglottitis. And then you see lateral neck x-ray shows the thumb sign, and I'm going to show you that right now. Hold on. Here you'll see the normal larynx, and here in the epiglottitis, it is closed pretty much shut, and breathing in is difficult. Making the cough sound out, you'll hear that barking sound. Inflammation and obstruction of the airway, increased pulse, restlessness, retractions, anxiety, and they're sitting like that in that triad position. Drooling is a lot. It says treatment would be to decrease the anxiety. Don't examine the throat, especially with the tongue blade. Position for comfort. You do have a trach tray or the endotracheal tube available. The cool mist is, there's those humidifiers, but sometimes they're just not strong enough. So locking yourself up in a bathroom with a little kid is like key. That's like mainly what you'll hear parents. Yeah, I slept on the bathroom floor with the baby and the steam going all night. My water bill is going to be this. My hair is so frizzy, I can't stand it. I'm so tired. But they get to the hospital and they've done the right thing. So now generally the 48 hours or the 24 to 48, the symptoms are lessening. And it says here, no oral fluids. So how do you hydrate the kids when they have this extreme epiglottitis? They will get an IV. And the IV fluids is what they'll keep them in. And usually the IV will be just in the ER. It's not generally something that they are going to be admitted for unless it's that very extreme case to where they're completely shut off. So that's all dependent on that. She speaks very well on it, so please do watch those. That is something that is very scary for parents. They need a ton of support. And in this season right now, RSV is big. There are at least 4 cases every time I go into the ER, at least 4 cases. So that is one of the things that is really scary very scary for parents, because newborn babies can get this, and it isn't something that we want to play around with just because of the symptoms. So here, nasal congestion, cough, rhonchi crackles, increased respiratory rate, work of breathing, respiratory distress, fever, and poor feeding. It could sound like a common cold. Babies get colds, but they go in, get the lab work, and if they're positive for RSV, it's one of the things that you want to try to isolate yourself. Other family members stay away from this baby or child. The parent or caregiver wears a mask when they take care of them, because we're seeing a lot of positive RSV in the older adults. And it can be they can get very, very sick. There's the palivizumab, or the Synagis, is used to prevent the RSV, but suction, bronchodilators, chest percussions, that kind of treatment, promote fluids, really generally treating the symptoms, supplementing the oxygen if in fact you are in the hospital or in an area in a clinic, and then reducing the fever, promoting rest. Isolation and hand washing is a big one. It is a respiratory infection. You definitely want to keep yourself safe. So you're going to be wearing your mask, which we already are doing. You want to be wearing a gown, and you want to really do a lot of good hand washing. It is respiratory and contact, but it isn't one where they're in a negative pressure room. I don't know. Oh no, you haven't been in Peds yet. Treating these symptoms can be very scary for the parents, because the first thing you hear in RSV, the respiratory syncytial virus is most common, and you hear that it's a child less than 2 years of age, and you're scared. So an upper respiratory infection is scary for them. And I have seen them in the pediatric intensive care. I have seen them be treated for this. So you definitely want to get that infant or child to the ER. If they deem it where it's already past the most critical stages and the child is doing fine, they won't hospitalize them, but babies do get hospitalized for this, and you'll definitely see them on Peds. We have our patients that have the asthma, and asthmatic parents, caregivers are generally tired, because this is an ongoing thing. You treat with your, generalized steroid inhaler and then a rescue inhaler. Little kids get the breathing treatments because it's much harder for a little child to manage their secretions than an older child. It's very dangerous for them. Managing an asthma attack, I don't know how many people here have asthma, know how scary it can be, and a child is helpless. They are definitely dependent on their caregivers to do the right thing for them, relievers, controllers, and preventers. We have the corticosteroids that maybe they inhale once a day, then, the other medications in combination to keep, any exacerbation at bay. And then if they do have an exacerbation, they have the relief inhalers, which are very important to keep on hand, and important to make sure that they have not been expired or empty. Just little things like that. An asthma attack can happen environmentally. Like, let's say you're driving with kids and one has asthma, and it could be this season where there's a lot of cough and cold, RSV, and you go by some area that is putting the slurry on the pavement. That happened to one of my students one semester, where they walked outside, got an inhalation of the slurry blacktop that they were doing on the upper campus, and immediately had a horrible asthma attack. But then we also had another student that called and said, I could get an asthma attack, so I'm not coming in because I heard they were doing slurry over there. So it just depends, but asthma is a scary thing. We just have a few more things to talk and I'll let you go. I'll push back the next section to the next time we meet. Cystic fibrosis. That is a tough one. Progressive chronic lung disease, chronic dry cough, recurrent upper respiratory infections with thick sputum, and chronic hypoxia. It causes many different problems. CF-related diabetes, abdominal distension, fatigue, growth retardation, rectal prolapse, fatty, stinky stools where they have to take a supplement so that the body can absorb the fat in the stools. Meconium ileus in a newborn can generally be the trigger to diagnose cystic fibrosis, but you do a test, the blood test first. The treatment is you increase calories and protein. Airway clearance of the thick mucus would be the chest physiotherapy, where they go in and they really do the pounding on the chest to do that chest toileting. Aerosols and bronchodilators, mucolytics. They check blood glucose on these infants and children. Aerobic exercise is important if they're able to, if they are able to sustain their breathing with that. And the meds are antibiotics periodically for infections, water-soluble forms of vitamins like A, D, E, and K so they can absorb it. And then the pancreatic enzymes to pull the fat out of the stool so that they can absorb them. In the old days, I don't know if anybody's ever seen the show, what is it called? The Midwives. Called The Midwife. It was a show back in England where midwives were birthing babies, and they had, a poor area in England. And some of the old nuns, to do the tests on the babies, if they suspected that they had this lung condition, they didn't call it cystic fibrosis, they would lick the babies. And if they had salty skin, they would know that they probably had that lung condition. Well, it was cystic fibrosis and salty taste on the skin because the body is excreting that. Primary symptoms, the lungs, coughing and production of mucus. They wheeze, short of breath, frequent infections of the nose, throat, and lungs. The stomach pain from constipation and gas, eating more than enough but not gaining any weight, and their failure to thrive. The diarrhea or thick, tarry, foul-smelling stools because the body is not absorbing that fat. Sweat and that tastes very salty problems, staying hydrated, having enough fluids in the body. And cystic fibrosis-related diabetes is one they develop when the pancreas becomes scarred and is having trouble making the insulin. Sinus lung infections, cystic fibrosis sinus infections cause a sinusitis. They often suffer from terrible headaches. The swelling of the area behind the eyes and nose and forehead, so constant headaches, fogginess, constant inflammation can create growth in the nose or polyps, which a student did put an NG tube in a patient that suffered from cystic fibrosis and went right through a polyp. So as they were going, all this blood squirted out, and the patient thought, oh, I have polyps. I was like, would have been nice to know that. The poor student's traumatized forever with that. But it's just an interesting side story. They suffer from heartburn and GI upset, esophageal reflux, or the GERD. Pain of heartburn is caused in the stomach, acids damaging the lining in the throat. GERD can lead to worse breathing problems for these patients if it goes untreated. And then bone, the CF have the trouble absorbing the calcium and the vitamin D, so they can have, a lot of premature fractures, osteopenia, and osteoporosis. Not a good condition to have. These are some of the infections like Pseudomonas, Haemophilus, Burkholderia, Staphylococcus, Escherichia, and Klebsiella, Escherichia coli, E. coli. That's all you ever have to say. Klebsiella pneumoniae, these are some of the organisms that affect these patients and have them hospitalized. Treatments, the PPD or CPD, the chest pulmonary therapy, physiotherapy, they go in, And honest to God, that little vest that's on that child, it looks like it's putting them in a carnival ride. It's shaking them and pounding them so hard. You walk by a room and it's almost traumatizing for me to see that. I don't know why. They're like getting shaken up so hard, and they're fine with it because they know that the end game is once that's off, they cough up a bunch of gunk that's stuck to the sides of the walls in their lungs, and they can breathe better. It's not as hard on a child as it is on the elder adult, because watching that, it looks like those poor old folks are getting the shit beat out of them, really. They're just pounding on them. And patients that have chronic lung diseases understand this, and they wait for this. They accept this. They enjoy this because they know that they are going to have, you know, a big cough up, a big lung secretion, or a suction, they get suctioned or whatever it is. And it's released these secretions that are so thick that they cannot manage, and they can breathe great for a while. Oftentimes, it's several times a day that they're getting these treatments when they're in the hospital. They're in the hospital a lot. They know all their respiratory therapists by name, and it is a lot for families and children. So recognize that if they're in the hospital with a condition like this, they are going to need family support. Like
Linda, on the previous slide with the photo of the pictures of the baby, what is that all about? The FGHI on the right hand side, what that where the baby, and it's got like the blue highlights for parts of the
it just shows the areas of the lungs that are affected in the bronchioles. It's just, you know, showing
different areas
in different positions in which they place them to get the secretions out.
Okay, so those are therapeutic positions.
Yeah, that's just like an example. These chest things, if you ever are on Peds and you see that, respiratory therapists, our respiratory therapists on Peds are so great. There's 2 guys and a gal. They are so great with these children. But watching these kind of chest percussions and those vests that go on are brutal. It really is a hard thing to watch for these patients. And like I said, if these patients suffer from these chronic respiratory conditions, they definitely want your support. They definitely need your help. And a lot of times those plugs in those blue areas where you saw Bear, those plugs get loosened up to where they cough them up. They cough up a lot of secretions. They throw up a lot. It's listening to the secretions can often, we're wearing masks, can make your eyes water and promote your own gag reflex. I know that has happened to many people. You can't help it. It's innate. You hear that, you want to throw up yourself. So poker face, you've got your masks on. So that is one saving grace. But remember that that is a thing, and you can definitely, you know, it's definitely something that you would be susceptible to if you've not been around it a lot. So don't be surprised if you have to leave the room. That's also something that is okay. You have to leave for any instance for that. It can definitely be one of those things where it can be embarrassing. I'm going to push the cardiac back because I've had you for a little too long, and I know you guys have stuff to do. So I'm going to go to our
Sarah
module.
had a question also, I believe, Sarah.
Yeah.
Yes.
Are there water-soluble forms of fat vitamins?
Yes, there are.
Oh, okay.
Yeah, there are. Let's see. So, okay, guys, watch this. Let's see if I can do it. Sometimes I can. Yep. And we're going to move it down here. But I was kind of hoping for this week on your own that we could do quiz number 2 then, unless there's any objections. So the morning that you have the week 7 ATI Real Life or Med Surg, I'm wondering why